This meeting is now being recorded.
Okay, we're ready to go.
All right. Hey, thank you, Sue. I appreciate it. And hello to everybody out there listening on the web. This is Dr. Bloom talking about one of my favorite subjects today, concussion. It's a subject that, of course, you're all very aware of in the media. You can't turn on the television nowadays or pick up a newspaper or read through Facebook without some headline about the issue of concussion, particularly in the area of sports medicine. But as many of you in the offices are aware, sports medicine and sports concussions are only one small component of the mild brain injury. We see mild brain injuries in motor vehicle accidents, industrial accidents, simple slip and falls, and, of course, sports. So those of you in the office practice are seeing concussion every day from a wide variety of sources. My interest in concussion specifically goes back many years. I trained at the Rehabilitation Institute of Chicago at Northwestern, and in my training in brain injury, I found the concussion patients very difficult to deal with, and you folks have seen this in your office. They have horrible headaches, they have light sensitivity, they're confused, they have mood issues, they're not able to get back into work or school, and I found them very difficult. In fact, I preferred to take care of patients with severe brain injury because they were much more obvious on what to do for them. So when I started here in practice at Mary Free Bed Rehabilitation Hospital in Grand Rapids in 1994, I set out to try to come up with a different model of approaching concussions. And it made sense to me that a team specialized in this, where the therapists, the doctors, the nurses, the psychologists all took care of concussions as the majority of the patients they saw. We could put together the expertise to handle this type of case. So that was almost 22 years ago, I guess now, and that's what we do here. So I want to talk about a little bit of what we do in our program and what concussions are and what we know in today's literature. I'm going to apologize if I'm a little hoarse today. Like many of you, I was up till wee hours in the morning watching the Cubs win the World Series. So I may be a little hoarse, and I apologize for that. All right, so today we're going to be talking about mild brain injury. I'm talking to you from Mary Free Bed Rehabilitation Hospital, and you got to forgive my Christmas slides. I heard the first Christmas commercial last week, which I thought was way too early when I was putting together this lecture, so I threw on some of our Christmas slides for it. So forgive me, we haven't even got to it yet. I have no financial support to disclose. And today we're going to be talking about concussion, which by definition. So on our objectives, we're going to review current concepts in concussion management. We're going to look at the signs and symptoms and the pathophysiology of concussion. And we're going to try to come up with an improvement in the knowledge of proper concussion assessment and or management of that injured patient, and review current concussion treatment guidelines, including return back to work, school, and sports. Now, what is concussion? By definition, it is a mild brain injury. There is, in the sports world, the Zurich consensus statement is a group of specialists from all over the world that get together, and they've redefined concussion several times. But I like to break it down to its simplest description. It's a traumatically induced physiologic disruption of brain function manifested by an alteration in neurologic function. By definition, it is a brain injury. We kind of hate that term of describing brain injury as mild, moderate, severe, and I'll kind of describe to you in a minute what a mild brain injury is. But make no bones about it, it is a brain injury and carries with it the implications of damage associated with the brain. By definition, it has some definable neurologic criteria. You have to see a neurologic deficit to have concussion. It's interesting how many patients we see in the clinic who actually don't have any neurologic deficit. They had a concussion years ago, and they think that, their difficulty at work or their mood disturbances is caused by the concussion. But there has to be a change that occurred at the time of that injury to the head to define as a concussion. By definition, you don't need a loss of consciousness. In fact, loss of consciousness is very rare, about 5% of patients. And interesting, prognostically, a loss of consciousness actually does not carry with it a worse prognostic indicator. post-traumatic amnesia does, but simply having loss of consciousness is not that important in terms of prognostication. By definition, they have a Glasgow Coma scale of 13 to 15 after 30 minutes, for those of you doing some of the initial assessments in emergency room visits or perhaps on the sideline. And again, you don't need PTE or post-traumatic amnesia. However, that's a very important prognostic sign, and we're going to talk about that in a minute. Now, the interesting thing in 2016 is up until very recently, the description of, quote, normal, quote, radiologic imaging is what defined it as a mild brain injury. In other words, if there was a change such as bleeding on a CAT scan or perhaps axonal shearing seen on an MRI, then it was bumped up to the, quote, moderate level. That technology has changed significantly, and we're on the forefront of having new imaging techniques that are actually going to be showing the microscopic damage to those neurons or the diffuse axonal injury. So that concept of normal radiographic imaging may go to the wayside soon. There's many etiologies of concussion, and we see all of these in our clinic. Simple slip and falls, motor vehicle accidents, work injuries, assaults, recreational injuries, and sports. About a third of what we see here at the Mary Free Bed program is sports, but the rest of it is motor vehicle accident and work injuries. Those are the big ones. Although we still see those crazy injuries. Last month, for some reason, we saw 3 separate cases where people sustained concussion by slipping on urine from their pets in their house. So we see it all. Now, let's talk a little bit about the mechanism of injury and concussion, which is definition of brain injury. I tell my patients and their families that the brain in the live human being is very gelatinous. You know, when you do dissections of brain, it's kind of rigid, it's firm, it feels like a softball. But in the live human being, it's very gelatinous, kind of the consistency of yolk in an egg or maybe Jell-O in a bowl. And that gelatinous nature of that causes that tissue to be very susceptible to micro irritation or diffuse axonal shearing or injury and microscopic edema. The brain, in effect, sloshes within the cranium when the head's thrown forward and backwards like a whiplash-type injury or a direct blow. In fact, in sports literature, they're starting to come up with a new way of quantifying what's called the slosh factor, which I think is a pretty funny term. But it's a description of what happens with that brain during a concussion. So what we see here in a concussion is a number of different injuries that result in the brain being damaged. You can have a direct force right to the cranium itself, which will cause forces throughout the covering of the brain. And this is kind of that direct blow that you see right through that area. And you may get, I often describe to my patients as bruising of the brain over that area of the cortex. However, those forces are translated all the way through the brain to the other side of the brain, where the slosh effect of the brain may cause that brain to then concuss across the inside of the hard cranium. And that causes damage to the other side. So it's very common when we do higher level imaging of these brains, or maybe neuropsych testing, to see dysfunction of the lobe of the brain, not only that was seen maybe in a direct hit in a football, but the other side of the brain may have deficits also. You also get a shaking phenomenon once this has occurred, particularly in those injuries that result from whiplash, say a car accident or maybe an industrial injury where the patient fell and hit his head and has a whiplash effect. You get this shaking damage that results in diffuse axonal injury. And then finally, a major source of damage in concussion is a rotational force right at the brainstem. The cerebellum and the brainstem is relatively fixed within the cervical spine and the cerebellum, and there's a rotational force between the upper brain and the lower brain. And we find that causes significant damage. In fact, that's where a lot of the more severe symptoms and also the long-term deficits come from. From a pathophysiologic standpoint, this is a diffuse injury. It happens throughout the entire brain, but we see focal abnormalities in the lobes. The most sensitive lobes are the frontal lobes and the temporal lobes. That primary distribution is a parasagittal white matter. That spreads from the cortex or the covering of the brain all the way down to the brainstem. And that's very consistent with the neurologic or behavioral symptom difficulties that we see. That's why we see changes in attention and executive function in these injured people. And it's very consistent where they have the damage. Now, if there's significant damage or rotational forces at the brainstem, that's when we typically see the loss of consciousness. And this is kind of the more common thing we see in football, where a football player is hit in the back of the head or the back of the neck, or there's a very rapid rotational force from, say, a face mask. And that results in diffusion and injury in the brainstem level and leads to loss of consciousness. Now, this is a very diffuse injury. It's a diffuse axonal injury. And again, we see normal CT and MRI, though on imaging, functional MRIs and SPECT scanning are very promising in the future to be able to help diagnose these concussions. Remember, concussion is a diagnosis of symptomology and some subtle neurologic findings, but we don't have any great markers yet in terms of labs or x-rays, although I'll talk about that in a little bit. Now, what happened from a physiologic standpoint at the concussion is at the time of the blow or time zero, you get this energy crisis. So what you get is a significant decrease in blood flow to the area of the brain. You get a significant decrease in the oxygenation over that area where there's this microscopic swelling, and you have this huge increase in the demand for glucose or the nutritional components for metabolism in the brain. In animal models, there's this deficit that's created by this blood flow, lack of oxygen, and increased need for nutrition that lasts for about 3 to 4 days before it normalizes back to normal. However, in humans and in animal models, we know that they continue to have their concussive symptoms following that, even though the metabolism is restored to normal. So why do we see that difficulty still going on after 4 to 5 days? Well, that's because damage has been done to the nerve cell itself. There's been a shearing force of the nerve cell. It's permanently damaged, and it may not recover. Now, from a neurophysiologic standpoint, in addition to the difficulty with lack of oxygenation and the decrease in the glucose metabolism, you also see this immediate biochemical changes. You get a huge efflux or loss of potassium and glutamate from the cell itself, and then the membrane becomes very permeable, and you get this huge influx of calcium. This is going to suppress the neurologic activity of that cell. In other words, cause it not to even work. There's this period of hypermetabolism after that because of diminished blood flow, and that's that period where the brain has to rest to get to fix that difficulty with the electrolytes that are out of balance and the nutritional and oxygenation status. If this damage occurs repetitively, in other words, if a nerve cell has repetitive damage, a series of concussions over and over, such as, say, a professional football player, you can develop what you've seen in the literature called chronic traumatic encephalopathy. This is the condition that was described in the movie Concussion, featuring Will Smith, based on the work of a pathologist named Bennett Omalu. I've had the opportunity to speak with Dr. Omalu on a panel in Lansing recently and a couple of weeks ago down in New Orleans. And it's a fascinating story. If you have not gotten a chance to see that movie or read his book, I would recommend it. It gives you good insight into the pathology itself and why it was such a mystery to discover, and then more importantly or interestingly, how it was applied to the football world. But what you see is enough repetitive damage to those cells that you get deposition of a protein called beta amyloid. This is part of the tau protein that is pathologic. And in the NFL brain donation program, they've had 63 brains from NFL players who have passed away that they've biopsied and found this abnormal tau protein deposition. And it's consistent with their chronic concussion symptomology symptoms that it's probably the causative factor. Interestingly, those athletes, for the ones that were tracked with concussion, there was a delayed onset from stopping their sports onset of symptoms about 8 years. So while they were playing, they didn't have symptoms of this. They showed up about 8 years later. So that's one of the endpoints of these concussions we see. Interestingly, in the athlete, the feeling is that it's not the obvious concussions that occur resulting in a loss of consciousness or being taken out of play, but probably a series of repetitive concussions through their whole career, what's called subconcussive forces. Every time they hit another player in practice or during games, during their whole career, elementary school, high school, college, pro football, is resulting in microscopic edema to those cells, or this diffuse axonal injury, leading to the CTE. fact, in linemen, it's estimated that they receive over 70,000 subconcussive forces during their career. So it is an important issue, and it's starting to be more clear that this pathology is related to that. How this translates to, say, a industrial worker who has a single concussion, or maybe a high school athlete who has a couple concussions during their career, it is likely that those single episodes are not going to lead to this CTE, although there's going to have to be more research on that. Now, we do know with repetitive concussion that there is a higher risk of difficulties. Dr. Guskevich and Associates about 13 years ago started a series of studies that they continue, and they looked at the number of concussions that an athlete had and the type of symptomology they had and how prolonged, and they found that a prior concussion was associated with a higher rate of subsequent concussion. And we do see that in our clinic and have all along. Furthermore, they did subsequent studies and found that the symptom duration was longer than those who have had previous concussions. In other words, if you have had a series of concussions, you are at a higher risk for a recurrent concussion or more prolonged symptomology. And we see that not only just in athletes, but people who have been in a series of car accidents or industrial injuries. And the most significant clinical thing for you to watch in your offices is those concussed athletes or workers who are still having symptoms from that concussion, because it's very important that they receive treatment and have a complete resolution of their concussion symptomology before they're put at risk for another injury of the head, because we do know that if a person has another concussion before the first one is completely healed, it is more likely that they will have more prolonged symptomology or worse symptomology. That's called the second impact syndrome. And so you want to make sure they're completely resolved before they get put back into a situation at work or with sports or recreational activities that they might have another concussion. The post-concussion syndrome is a description of the symptomology, so I want to spend a little time on this. And by the way, I hate that term, post-concussive syndrome. If you Google that, there's tens of thousands of hits that describe every symptom known to man being attributed to concussion. It's just not true, but we have patients come in all the time who are convinced that chronic unrelated conditions were caused by their concussion. But you can lump them into major categories, and these are kind of the main ones we see in our clinic. That includes headaches, balance dysfunction, problems with cognition, decreased memory concentration, pain, both neck and headache, and cranial myofascial pain, visual disturbances, mood disorders, and sleep disorders. Those are the major ones. Now, there's subcategories in all of those. There's a number of overlaps on these 22-sided symptoms, but those are the ones we mainly look at. In our clinic, the most common ones by far are cognitive. We see problems with decreased attention, concentration, and memory. And those patients with chronic symptomology, in other words, more than the initial acute phase, about 18% of those still have symptoms at 3 months after the concussion. And even, we track our patients long-term, even at 1 year post-concussion, about 6% of those are still having problems with concentration, attention, and memory. So it is a very significant issue. Headaches are very significant. That's the more acute phase. So about 42% of the patients that we see still have headaches at 3 months. And even a year later, about a quarter of them still have headaches. So it's a pretty significant issue. Problems with vestibulopathy or dizziness, in layman's terms, is a very significant problem. This is probably underreported at 23% at 3 months because testing to date has not been super sensitive until recently. We now have the Balance Center at Michigan, at Mary Free Bed, where we're looking at vestibular dysfunction very early, particularly in physical employees and workers and also in athletes, to try to help in their rehabilitation. And even a year later, 15% of them still have difficulty. In fact, the number one reason we can't get most athletes back to play if they struggle is because of vestibulopathy, not because of headaches or cognition. And about half of the patients who present to our clinic have problems with mood or emotional lability. Now, they may have had a problem with a mood disorder premorbidly, depression, anxiety, but the concussion itself may make that worse, exacerbate it, or it may be a reactive depression because of the problems with pain and frustration, a lack of sleep, and not being able to play sports or work. So those are the most common things we see in our clinic. Now, I'm going to be talking a little bit about the different reasons people come to the clinic. And I'm going to be kind of toggling back and forth between sports injuries and work-related injuries, because that's the vast majority of what we see and probably what you'll see in the office too. And though the pathophysiology is the same between sports and a work injury, the approach to them is actually a little bit different for a few reasons we'll talk about. In the world of work-related concussion, up until recently there wasn't much data available from a majority of the concussion epidemiology sources. Scott Primack and Associates estimated about 480,000 work-related head injuries a year in the USA, and that's probably unreported. However, the occupational medicine programs, which we have some wonderful occupational medicine programs in West Michigan, are doing a lot better job at tracking that and at picking up on that a spinal injury or a slip and fall may have resulted in a head injury that was undiagnosed. There are some commonalities between work-related concussions and, say, recreational activities. You tend to see more injuries in the males because they're at higher risk than females. You have a higher incidence of those in the risk-taking age 20 to 25%. And in our data at Mary Free Bed about 3 years ago, when we looked at about 500 referrals, about a third of those were industrial injuries, so work-related injuries. So it's a very common problem. In sports, the numbers are a little different. In JAMA, they published an initial series with Dr. Powell and Associates who underestimated that there was about 300,000 head injuries per year in the USA in sports. That's very underreported. In fact, it's probably about 4 times that. Just in high school that year, they reported 63,000 mild traumatic brain injuries. Now, the majority of these concussions heal relatively quickly. About 85% of athletes evaluated for concussion had headaches lasting for a week or longer, but the vast majority of those sports-related concussions will resolve very quickly within about the first 72 hours. Of those that persist symptoms, it's not uncommon for them to have symptomology for 3 to 6 months afterwards. And in fact, about 5% of the concussion patients we see will have symptoms lasting longer than a year. So though it's described as being a mild traumatic brain injury, it is not a benign issue. So how is that assessment done? It depends on whether it's an industrial injury or a sports injury. The initial evaluation for mild brain injury can be done in a variety of sites, and you see these patients right in your office. It may be in a primary care physician's office. It may be in an occupational medicine office. But sports is probably right on the sideline, and of course, a pair of these end up in the emergency room. So we do like to look at the documentation at these initial evaluation sites. And we really like when people document loss of consciousness, post-traumatic amnesia, and Glasgow Coma Scale, because that helps us with prognostication. We like a documentation of a mini mental status examination if that's a tool that's available to you in the office or the clinic. And we'll talk about a couple different tools that are very easy to use and readily usable between different examiners. We like a documentation of focal neurologic deficits, maybe pupillary abnormalities or any hemiparesis or clear vestibular findings. We like to know if imaging studies were done and the results of those, an X-ray or particularly a CAT scan of the brain. Again, these tests don't have to be done in concussion, but if they were, we'd like to know them. The most important thing about that initial evaluation is a reassurance and education to the injured person that the prognosis for recovery is excellent, but it's going to take some time. So managing their expectation is important. And it's also important that they be taken out of any risk of another injury. So obviously at work, that they're taken off of that particular job for a period of time, or sports, that they're taken out of contact sports until their symptoms resolve and they get cleared, or they're referred to a concussion treatment program like Mary Free Bed. And again, if they continue to have those symptoms, that a referral is made to a concussion clinic. The million-dollar question we always are asked is, at what point in concussion recovery do we want to see that athlete or that injured worker? The vast majority of these will clear relatively quickly. They're being evaluated in the primary care office or by an athletic trainer or sports medicine doctor. And within 72 hours, if the concussions are cleared with no neurologic symptoms or subject to symptomology, they can return back to that activity. Typically, if that symptomology goes on for about a week, that's a good time for them to refer them to a concussion program like we have here at Mary Free Bed. Well, they'll be assessed in the clinic and then treatment initiated if needed. We'll talk about that treatment in a minute. Diagnostic testing, by definition, is usually unremarkable. As we talked about, a plain X-ray is not going to show anything with the brain, but you're looking for skull fractures if that was a concern. CT of the brain, MRI of the brain, of course, are by definition normal. It's interesting, there are a few electric tests that have been applied who have some utility, like quantitative EEG, looking at electrical abnormalities of the brain, brainstem auditory evoked potentials or visual evoked potentials. However, I wouldn't recommend sending out for these tests standardly on concussion patients. The sensitivity and specificity of these tests is pretty poor, and every once in a while we'll have a reason to get this test if we have a concern about one of these pathways. So in general, you wouldn't refer out for one of these tests. Brain CT and MRI should only be employed when there's a suspicion of an intracerebral bleed or some sort of structural abnormality, like a subdural hematoma or a subarachnoid hemorrhage. You don't need to do a CT or an MRI imaging. If you're going to do a CT, you would prefer it to be done the first 24 to 48 hours, or if they had worsening symptomology during that first 72-hour window, increasing headaches, increasing photosensitivity, mental status changes. But again, in the vast majority of mild brain injury, the CT and MRI are normal. And again, as we talked about earlier, there is an emerging role for things like functional MRIs or spectroscopy or diffusion tensor imaging. It's not being used in practice yet, but I'm sure we'll be seeing these imaging techniques being used in the next 5 years pretty regularly. That initial evaluation, of course, you want to start from the basics. You want to confirm that airway, breathing, and circulation is intact. Assess their level of consciousness, and establish the presence of any loss of consciousness. The longer the loss of consciousness, the less favorable for the prognosis. But more importantly is amnesia. And amnesia is much more common than loss of consciousness. The presence of amnesia would carry with it a little less favorable prognostic outcome. Now, we grade amnesia as being retrograde, in other words, a loss of memory from just prior to the accident, or anterograde, which is a loss of memory from the time of the accident. If there's presence of retrograde amnesia, in other words, the athlete or the injured worker can't remember something that occurred right up until that time, you may ask them, they might not remember anything from that day. That their last memory might be eating dinner the night before. That carries with it a much less favorable prognosis. On site, you want to make sure you document some of the signs of concussion, confusion. Do they have problems with impairment of awareness or orientation of surrounding? They may appear stunned, dazed, glassy-eyed. Often this is recognized by the coworkers or teammates before the boss or the coach or the parents. And you want to make sure you ask simple orientation questions on that. The symptoms that they have, again, is one of the most important ones to look at is amnesia. And, of course, that's the duration that we just talked about related to severity of injury. The anterograde amnesia, a period of amnesia following the injury, and then retrograde, that period of immediate preceding trauma. And so that's much more predictive of post-injury cognitive deficits and persistent symptoms if they have that retrograde amnesia. Interestingly, that will shrink over time, too, and that's a pretty common thing. Injured concussion patients are often very concerned about the amnesia itself, but it's really of very little consequence other than the anxiety it presents. And again, as we said, presence of amnesia, not loss of consciousness, is most predictive of post-injury difficulties. Dr. Kelly, Jim Kelly and Associates, looked at workers with significant cognitive deficits and a high degree of symptoms, and they were found to be 10 times more likely to have had retrograde amnesia and 4 times more likely to exhibit anterograde amnesia. So we see that in both the sports and the industrial concussion patients. Now, there is a relationship of initial markers and outcomes. So patients reporting that amnesia following concussion, they had more symptoms, longer duration of symptoms, and decreased test performance in those that we knew neuropsych testing on. So it's all the symptoms. It's headaches, the dizziness, the balance, the visual deficits, and the cognitive deficits. So what do we do to screen that? How do we, other than a patient just saying it, is there an objective set of tests or an objective scale to use based on subjective symptomology? We don't like to rely on any one test. We like to use a series of screening indicators in assessing and then tracking their recovery. And this would be a combination of cognitive screening, physical exam findings, provocative maneuvers to reproduce their symptoms, and standardized screening tools. We've done very good in the sports concussion world of coming up with a series of tools to use that are utilizing all four of these domains. The symptom scale test is a very simple test or a simple scale that you can use as a questionnaire with the injured patient to try to determine their symptoms on a scale of 0 to 6, being none all the way up to severe, based on all the subjective symptomology, dizziness, headaches, nausea, vomiting. And then you can do this at the initial onset of the concussion or when you first see them in the clinic. You can do a 48-hour recheck. You can do them all the way out until they have complete resolution. And this is integrated in one of the tools we'll talk about, which is a sports concussion assessment tool, the so-called SCAT. It comes up with a scoring system, not really to be used for definitive return to play or not, but to follow over time. And it's a little card-based test that can be kept right on the sideline or maybe in your clinic that correlates all the subjective symptomology that they have along with objective testing and return to play guidelines. So this is a sport concussion assessment tool 3, which is very helpful. In our sports concussion network, all the athletic trainers, sports physician specialists, and residents all carry a SCAT card with them to do the scoring. Another test that, scoring system that we frequently use is the ACE. That's the Acute Concussion Evaluation. This has been around for about 10 years now, and it's part of the CDC Heads Up Kit. And at the end of this lecture, I think I have a couple different references for the CDC. They have a very nice set of educational tools that you can use that are very nice, I think, in the clinic basis or the primary care physician office to assess and manage concussions. And if you go to cdc.gov/concussion/heads-up, you can download a whole number of different tests to do, including the acute concussion evaluation. This allows for initial evaluation care and allows for individual assessment of brain injury. Now, let's talk about treatment. In the old days, the treatment for concussion was rest, right? Cognitive rest, physical rest. Well, there's been a series of papers that have come out that have shown that rest more than 3 days may actually be deleterious to the recovery of brain injury. So we've kind of almost thrown that whole concept of absolute rest out the window. And in fact, what we've really found out through our clinic is that it's important to keep concussion patients doing some sort of activity. Now, maybe somewhat limited activities, such as part-time school or limited hours at work or restricted work. But gone are the days where we tell concussion patients to stay in a dark room until they feel better. The brain actually needs to be stimulated to heal. And once you get through that acute phase, we found years ago that being very proactive on the rehabilitation of these patients is really what helps them recover much quicker. So with this, there's a number of indicators for successful outcome. One is diagnosis of the concussion early. Well, that may speak for itself, but it's very important to make sure you diagnose these concussions, particularly in the sports-related world, so that the athlete's not in there playing with a concussion, getting worse concussive injuries. You want to make sure you educate the employee, the coaches, the family, and the employer on what to expect with this. You guys have probably all seen that concussed patients are very frustrated with particularly employers or maybe principals at school that don't understand the injury and think that the employee might be faking their symptomology. I often hear particularly workers wish they had a broken arm and a cast because it's something they can show to their employee that they're injured and that they just don't understand the concussion. And, of course, don't just rest them, treat them. And this requires a cohesive team treatment with a consistent message. Once we get their symptomology doing better and they're healing, then the team works on a pacing of a graduated and successful return to work or school. So in the clinic, we break down their symptomology into a series of different etiologies and our approach to that. Post-concussive headaches are one of the biggest things we see in the clinic, as we talked about. And so we try to break these down into musculoskeletal headaches, vascular headaches, and neurogenic headaches, because each of these is going to require a different approach to that. Obviously, we use a fair amount of physical therapy with emphasis on posture, range of motion, and strengthening. We want to try tapering off of any pain medications relatively quickly, particularly narcotics. It is okay to use a pain medication in the initial phase after concussion for the headaches or maybe the neck pain, but you want to really limit it to just 24 to 48 hours and then taper off rapidly. Most people are familiar with the concept of rebound headaches, that if a patient is taking a narcotic or even a non-narcotic regularly, this will reduce their headache threshold, and when the medication wears off, so to speak, they will get worse headaches. We see a lot of sleep disturbances in the concussed population. You want to make sure you treat those sleep disturbances with appropriate sleep hygiene. Try to limit sleep medications and really do more education on making sure that the concussed individual gets to bed the same time, gets up the same time, avoids caffeine after a certain period of time, and, of course, no alcohol during that period. We do a fair amount of interventions. We do a lot of trigger point injections for the hemicranial and cervical myofascial pain syndromes. We do a fair amount of occipital nerve blocks for the occipital neuralgias, particularly when there's blunt trauma to the back of the head and neck. We do Botox injections, not only for the chronic headaches that are associated with concussion, but a small subset of concussed athletes or industrial workers will develop cervical dystonias, and we will use Botox in that. In our clinic, we do a fair amount of manual medicine, or in the osteopathic world, osteopathic manipulative therapy that is done with both the physical therapists who have special training in that and the physicians who also do manual medication. And medication management in the concussed individual is really focused on specific symptomology. There is no magic concussion pill. I wish I had that. I would probably be wealthy and famous if I could come up with that. But we really try to minimize medications in concussion recovery and focus on the physical recovery. Now, another big problem that athletes have in addition to those headaches, of course, is cognition. If you remember, that was a significant number of the problems that our athletes and concussed workers have. Treatment for it, there is not a magic pill for cognition. We do use a fair amount of cognitive rehabilitation within our program, but there's really very little role for cognitive therapy in direct treatment of the cognitive deficit. Programs that allege treatment for attention memory really just is not acceptable. It's a pragmatic approach. We do describe it as exercises for the brain, but what you're really doing is trying to refocus attention and reintroduce these injured people back into, say, work-related activities or school-related activity or sports in terms of the cognitive realm. And it's a very graded, slow return to those activities. And only pragmatic programs are shown to be helpful. Speech therapy for adaptive strategies for school or work, psychology or social work for counseling and vocational support. Vestibular dysfunction is a huge difficulty we see in both the injured worker and the athletes. In fact, at least about 50% of concussed patients, which, of course, we found in our literature, too. Up until about 10 years ago, there was only one big study that looked at dizziness in workers getting back to work. Now there's more research going on. In fact, that's one of the areas of research we're focused on here at Mary Freebed. And in those who are not back to work at about 6 months, about 30% was because of dizziness. In the athletes, it's even higher than that. So it's a big issue. So our physical therapy and our vestibular rehabilitation program that we have here is one of the big areas of focus for vestibular dysfunction. Just trying to pull up the next slide here. And I'm having a technical problem. There we go. Visual disturbances are also very common with concussion. Not necessarily diplopia. We do see diplopia in concussion. That results in either a pretty significant injury to the visual tracts and optic nerve, or they may have had, say, an orbital rim fracture that changes the mechanics of the muscle of the eye, even though the brain CT is normal. So we kind of see a combination of both of those. Occupational therapists focus on exercises for the vestibulo-ocular reflex that can help with this difficulty with their vision. We may change their prescriptions. Blurriness is a very common complaint they have to have, and we may even use prisms if there is tracking deficits. We work with neurooptometry on this along with the occupational therapist. We want to try to limit prisms to not too long a treatment because they can cause long-term problems, but they're used in the short-term area. Oftentimes we'll use patching if there's a significant problem with diplopia. On the concussion patients, that's not usually as common. What's more common is photosensitivity, light sensitivity. Unfortunately, there's no magic pill for that. There is some medications that help diminish that. In post-traumatic headaches, we commonly use a medication like Topamax or another seizure medication. We try to avoid them if possible because they do cause some problems with cognitive functioning and cognitive speed of processing. So we try to reserve them for the very severe cases, but that sometimes helps with that photosensitivity. The dark sunglasses are definitely appropriate during that acute phase. However, sometimes the dark sunglasses become a little bit like a crutch, and they also stigmatize the concussed person amongst coworkers or family. So we try to wean them out of those dark sunglasses as soon as we can. In fact, we found in the eye literature that the dark sunglasses long-term actually sensitize the eyes, so it is important to try to wean your patients out of those dark sunglasses pretty quick. Depression is a big issue in the concussed person. And as we said earlier, they may suffer from premorbid depression or mood disorder anyway, and the concussion exacerbates it. That's an organic exacerbation or a biochemical exacerbation. But also, concussed people just feel lousy. They have headaches, they have dizziness, they don't feel good, so that's going to make their concussive symptomology worse. So oftentimes, if they were already on a medication, we may need to increase that medication. There are new SSRI agents out there that have dual indication, including depression and headaches. So we may change their medication if they're on it. If they have not been on a medication or they did not have premorbid depression or mood disorder, we try as much as possible not to initiate it unless it's very severe. And we rely on our neuropsychologists and neuropsychometric testing to help determine that. Counseling is a big part of it. The neuropsychologist is a regular part of our treatment team. In fact, every new assessment other than young sports concussions gets a neuropsychologic screen the day that they're evaluated. So we have a very good feeling on how the mood disorder is being affected with this. And again, depression with concussion in treatment is really only useful for the depressive symptomology. It's not for cognition. People are under the impression that we use antidepressants to help with focus and memory, and that's not true. It's there predominantly for treatment of the mood disorder, and with that, sometimes you get improvement on the focus and memory. All right. Now, there are a number of concussion functional outcome tools, and I'm not going to review through each of these. They're on the handout at the end. But we use a fair amount of tools within the program itself. The dynamic gait index is an assessment we look at that's very important not only for the athletes but the industrial worker who has to be very physical and may have to climb a lot of ladders and be very safe with that mobility. Time get up and go test is another fact that we look at that along with the dizziness handicap index, looking at their dizziness. So it's not just the athletes that have problems with this physical activity, it's also the industrial workers. So we follow those outcome tools as they progress. Now, when we're talking about the injured worker, a return to work is often very difficult. So one of the things I mentioned earlier, particularly on the front line where you folks are, if possible, try to keep a concussed employee working. We find that if a concussed worker is taken off from work and it's prolonged, it's very difficult to get them back to work. Part of that is a learned behavior. There might be issues associated with the workman's comp insurance system. There may even be litigation. So it is true in all the literature and what we see, the longer you keep a worker off from work, the much harder it is to get them back to work. So even if they can accommodate a sedentary job or maybe a low stimulation job, then try to keep them working at least some degree as they heal or if you need referral to the concussion program. Once they're referred to our program and we're treating them, then we do a graded return to work depending on the response to their activities. So we have a 5-stage graded return to work program. The first stage is very light exercise, maybe 30 to 40% of maximum heart rate. That would be stretching, walking, isometric. While we progress through the rehabilitation, if they are able to do that asymptomatic, then we progress to stage 2, which is a light exercise, light weights, maybe 40 to 60% of maximum heart rate, along with balance activities and head position changes. If they tolerate that well without increasing their symptoms, then we go to stage 3, which is moderate aerobic exercises, about 60 to 80% of their maximum heart rate, and increasing strength exercises, running, and challenging dynamic balance exercise specific for their job. Stage 4 is heavy exercise, up to 80% of the maximal heart rate, along with job-specific training. And then stage 5 is a full return back to the activity. Now, depending on the work site, sometimes that can't be accommodated on the work site, so we'll do this with a work hardening program until we get them to stage 5 and allow them to release back into the regular job without restriction. Now, when we're returning those injured workers back to work, there's a few things we want to consider. One is a stepwise progression. And that may take actually weeks and a gradual increase in maybe their lifting requirements or their number of hours worked or their jobs that they do. The occupational therapists in our program work very closely with the employers, and oftentimes they'll do a work site evaluation to try to determine if we can accommodate some restrictions or increase their hours. Most commonly, we'll do modified hours, for example, starting out 4 hours a day, 3 days a week. And a worker with a high symptom score may be taken out of that work for a shorter period of time before we get them back. We want to encourage a lot of common sense things, and we work very closely with the employers on this to allow increased breaks, maybe 5 to 10 minutes every 1 to 2 hours. Limited computer time, taking a break every 30 minutes or every hour, and follow their symptom scores along with clinical monitoring. You want to avoid the progression to the next stage if symptoms occur. And so when the employee gets back to work, our team is following along with them and the employer to try to get to the next stage as long as they tolerate it. And then, achieving medical endpoint for work-related concussions is difficult. Many of the symptoms really can't be seen, and a fair amount of the things we do in our program is educating the employer about that and what the expectation is, managing expectations, everything. It may take longer with concussion based on concussion information for employees more so than sports, because most employees are doing this 8 hours a day. Other than at the elite level, athletes are not typically doing their activity 8 hours per day. So in the work-related injuries compared to the sports, it may take longer. We also see this one all the time. Coworkers and employers may not be as empathetic or sympathetic for this type of injury. We see this one constantly. And that's sometimes why the injured worker wants to even avoid going to work at all. They don't want to feel like they're being judged or that someone is comparing their work effort to the others. So again, that takes a lot of education. And then the endpoint can be achieved when the symptoms are resolved, balance testing is back to normal or back to its pre-injury baseline, and neurocognitive data is within acceptable range to get back to that activity. So a graded slow return is the best way to do it, if that can be accommodated. Now, in the sports world, it's a whole different picture. The return to sport has to be tracked very closely and then ultimately cleared by a physician with expertise in sports management or at least concussion management. The Michigan High School Athletic Association concussion guidelines were adopted in 2010, and that was carried over from the National Federation of Sports. So an athlete with signs of concussion is removed from all play and not allowed until they're completely cleared by a healthcare professional. It doesn't have to be just a physician. An APP can do this also. And one of the main reasons was this to make sure that that athlete was screened and then make sure that their concussive symptoms were completely resolved before they got back. Before 2010, oftentimes the officials on the sideline were asked to assess the athlete and determine if they should come out. So this removes their responsibility. It was a very important and good rule to institute. Mary Freebet, our graded return to sport activity is similar to the return to work activity. The first step is relative rest until asymptomatic, physical, mental. But as we were talking before, we don't do complete rest anymore after that 48 hours. We try to get that back into some limited activity. That might be school. That might be some socialization. with friends and family. We don't want them in total rest anymore. The second stage when they're in the program is just light aerobic exercise, less than 70% of maximum heart rate. Remember, these are athletes, so we can usually push them a little bit more. For example, a stationary bike. Then we want to, if they're asymptomatic at that level, then we move up into level 3, which is sport-specific exercise, again, drills specific to the athlete's sport. Level 4 is non-contact training drills with their fellow athletes. That's more intensive sport drills. Still no contact. If they're asymptomatic up till that level, then we progress to stage 5, which is full contact in practice once they've been cleared by us, not into games yet. And if they go through that stage, then we return them to full competition without restriction. The speed with which they progress through this depends on their symptoms. Now, we may, in an elite athlete or professional athlete, such as the Griffins, we may progress them very rapidly through all 6 of these stages over the course of a few days. But obviously in high school or adolescence, we're going to do this graded return much slower just to make sure that there is no residual difficulties. Now, are there concerns with this? Of course there are. The science on this is pretty weak still, so this is really more pragmatic approach to these patients. And of course, every case has to be individualized. You know, there's concerns. Have we returned people too quickly? Should the guidelines be based on neuropsych testing? And maybe those are too lenient. We always get the question about standardized computer testing like IMPACT or Head Start. And oftentimes it's decided to return an athlete based on that testing, which is not appropriate. They may still have objective findings on their testing unrelated to the cognitive deficits. So the concerns on that are pretty significant in the literature and in the research right now. In fact, ongoing research suggests that there's abnormalities in the EEG recordings or transcranial magnetic stimulation or balance testing, PET scans, and functional MRIs that still show persistent damage for weeks after athletes report normal symptoms and objective testing is normal. So that's a big concern. So in other words, the brain probably is still healing, even though every indication we have is that it's healed. Those studies suggest that it may indicate that a safe return to work or sports might require an additional 4 to 6 weeks of non-contact activities to facilitate a more complete recovery and to protect from re-injury. In the worker, that's not such a big deal because theoretically they're going back to a safe work environment where their head wouldn't be injured. But in the athlete, that brings up a big philosophic dilemma: is should we be keeping these concussed athletes out of play even longer? There is not a good answer on that. It brings up very serious questions. What's the significance of cognitive deficits after all the other symptoms are resolved? Or they have no symptoms, but they test abnormally on neuropsych testing. What about the opposite? What's the significance of symptoms, even though their neurocognitive testing is completely normal? And how back to baseline does a person really need to be to go back to work or sports? Can they continue to work with a concussion? Well, they probably can, as long as the head's safe, as long as they're not at risk of hitting the head again. Sports, it's a whole different answer. So even though these are similar pathophysiologies, the approach to them are a little bit different. So these are big questions that we have not answered, I think, in the literature. So confused? I'm still confused. I've been doing this for 25 years now, and I still feel like I don't have a great handle on concussion. And where are we now in 2016? Well, there's good literature out there. There's a number of studies coming down the pike. And I think in the next 5 years, we're going to see some big breakthroughs. One will be on imaging and concussion. That will be radiographic imaging that will confirm where a lesion is and perhaps in serial studies determine when the lesion is healed. The other is going to be biomarkers. I think there's 2 different major studies going on right now that have moved into at least human clinical studies, looking at a blood test, for lack of a better word, that will measure the amount of tau protein that's within the system or some biomarkers that indicate a concussion has been there. So there's some very exciting research going on, and I think we'll have that very soon. Then the elusive concussion drug is also out there in the literature now. There's a couple different studies that have not gotten to the human level, but will be coming out within about 5 years, I think. One is a medication that works at the cellular level to remove the protein that is deposed in repetitive concussion, the CTE protein. And so that would be used in a person who's had a series of concussions, who's clearly manifesting evidence of CTE, and that this medication would, in essence, remove the protein there. In other words, remove the damaging particle that's left with those cells. There is another series of tests that are going on right now looking at what's being described as a sideline concussion pill, which would be an immediate treatment to decrease the secondary insults of concussion in the brain, to rapidly decrease the amount of swelling that's going on in the cells and to decrease the damage that's done during that metabolic crisis. Of course, neither of these techniques are being used in humans yet, but I think we're going to see that pretty soon. And it's kind of the holy grail of concussion management, is to try to figure out a treatment that can be initiated very quickly and not just have to rely on the rehabilitative techniques we were talking about early. None of those are going to completely eliminate concussions, of course, and we're still going to need the rehabilitation, but at least there's some exciting things coming down the pipe. So in summary, I want to leave a couple minutes for questions. We'll conclude, that the current information of concussions needs to be updated and improved constantly. We have good success rates are possible with early and appropriate treatment. Our return to sport program at Mary Free Bed is 100% for this quarter on getting all athletes back on unrestricted play. You want to work on modifications of workplace, school, and sport. That's critical. And you want to consider the effects of multiple concussions in long-term issues. And that we feel that a multidisciplinary brain injury rehabilitation team may be the best way for an athlete or an employee with persistent symptomology to get back to either sports or their regular work. Here's a few concussion resources for you. The Brain Injury Association of America, and we have a subdivision in Michigan that's very helpful. The www.cdc.gov is a very important one, too. They have something called the Heads Up Toolkit. And if you're office-based, I'd recommend looking at that resource because there's easily downloadable forms that will help guide you in your assessment and treatment of concussion patients. And so I think we're almost done here. I've got my having trouble with my pointer. There we go. All right, there's my final slide, and I'm happy to open up to any questions that you may have.
This is Karen. Is there anybody that has questions? Please feel free to ask them. Doesn't sound like there's anybody. Dr. Bloom, thank you so much. This was a wonderful presentation.
All right,
very
great.
interesting. Yes,
yep,
very interesting.
And if any listeners out there have specific questions, we're happy to entertain them. You can send them over via email or just contact Melissa directly, and we're happy to follow up.
Okay, thank you very much then. Just a reminder to everybody out there listening that you can use the link on the last slide to go do your evaluation. And there is no password this time to get when you submit. It'll take you to your CEU. Okay? All right. Thank you again. And we hope to all hear and see you again soon.
Thank you.
Any questions? Okay. Then we'll call it a day today. Thank you again.
Thank you.
Here it is.